Yeah, I think there's lots and lots and lots in the TUR, in the office cysto, and in the path. And maybe I'll just start out with this. My red flags are going to be widely invasive laminar propria invasion, lymphovascular invasion, variant histologies. Those are where my alarms are going off oh boy, we got kind of a problem here.
Totally agree with you. And I always start the conversation with a radical cystectomy is going to be the best thing I could do for you right now to prevent you from dying of bladder cancer. However, in the community, and this is, I think, an interesting community phenomenon, if I say you need a cystectomy, there's a decent chance that, and not all patients are different, there's a decent chance a patient's going to get another opinion. And the ability for me is, that message coming from an academic center, I think is better received because the academic site is usually the end, right? The end of the journey. And so I will tell you, for better or for worse, I kind of, I always start with that discussion, but I think I present the other options maybe a little bit more generously, if that's a reasonable way to say it, because, and as we know, it depends on the patient, it depends on what's going on. There's a lot of factors involved. You can kind of see it in their eyes, right? When you tell them that your bladder's coming out, and you in an older patient, you need an ostomy bag. You can see in the family's eyes, you can see it in their eyes, and you can say, well, there are other options. They're likely, there are a higher risk of relapse, higher risk of progression with some of these other options, but this is something that could be worth a try. And I think the cool thing about this era of all these new treatments is it's going to test a lot of that. We're going to start to get a lot of data on how many of these patients are actually progressing, how many of these patients are holding on to their bladders, right? Adstiladrin had some good data that they published, about 5-year data, that even though they had patients who recurred, a really high percentage of patients still had their bladder within 5 years after they started that trial. So while you may recur, my feeling is that if you select your patients well and you're doing this, you're diligent about how you're treating patients, my feeling is that you're not letting a lot of patients progress. So I think recurrence is going to be somewhat common. Hopefully we pick off progression and we pick off those patients earlier. But as you mentioned, we don't know who those patients are. ctDNA may help down the road. Genomics may help down the road. MRI staging may help a little bit down the road. But I agree with you. But for pure CIS, there's data now that 5-year rates of progression to muscle-invasive disease are actually pretty low, right? 20 to 30%. So I'm of the camp, and I definitely know people will argue with me, and I'm happy for people to throw tomatoes at me here, but I think that if it's CIS alone and there's a quantitative improvement on therapy, that we should keep trying to find bladder-sparing options. Obviously, it's a discussion with the patient. You talk about the risks, but that's kind of my impression.
No, and I totally hear you. When I came out of residency and fellowship, anybody with muscle-invasive bladder cancer, the only options were neoadjuvant chemotherapy followed by cystectomy. That was it. There was no, let's get rid of the neoadjuvant, let's pickle them until they're a shell of the person they used to be, and then take out their bladders, chemo radiation. That's not really something that was kind of prime time. And, now we all live in the real world. And, I just had a wonderful conversation with Ashish Kamat, and he's like, we don't give everybody neoadjuvant chemo. Well, yeah, it makes sense, right? If they're old and they're sick and they're frail, or if you're hard to quantify, not worried, you're kind of taking all of that into it. So I hear you. And I think it kicked off with, you at least have to mention it. I think that's where, when patients are, I wouldn't say falsely misled, but maybe not just given the gravity of their disease. And obviously, non-muscle invasive bladder cancer is a huge heterogeneous disease state, right? T1 high grade nasty player versus small solitary TA high grade. Those are different. So I appreciate that.